I am Dr. Abdul Rafe, and today we are going to start our module on bladder tumors. This will be the first presentation on bladder cancer in which we'll focus on the epidemiology, clinical presentations, risk factors, and how to diagnose and initially evaluate the bladder tumor. Today's presentation. Today's presentation will be moderated by Dr. Pradeep. So, bladder cancer is a common neurological malignancies. We see it daily in large numbers in our clinical OPDs. And it is a very well natural history. At one end of the spectrum, there are low-grade papillary tumors with low progression and which can be initially treated with an endoscopic treatment. However, at the other end, they are extremely high-grade, potentially dangerous and associated with high mortality rates and death rates. So tobacco is a very common recognized risk factor associated with 50% of cases of bladder cancers. The great majority of neoplasms are epithelial in origin, but there are many other different histopathological types present as well. So in today's presentation, we'll focus on the incidence rates and the mortality rates across the globe in Pakistan, and what are the other risk factors, how it is presenting in other genders, various genders, what is the geographical distribution of bladder cancer, what are the recognized risk factors, how it clinically presents, and in the end, we'll focus on initial evaluation of bladder cancer. Just a word on anatomy of the bladder. The bladder is a hollow organ that lies in lower abdomen, sort of a reservoir for urine until you are in a socially acceptable place to void. It is lined with a specialized epithelial lining known as the urothelial lining, which accommodates urine under pressure. So these are the layer in which become very important when we are discussing the stage and stage of the bladder tumor, and the different T stages are on these layers of bladder. So we have a urothelium followed by lamina propria, muscle, serosa, and outer layer is a fat layer. Let's start with the epidemiology. So bladder cancer is one of the most common urological malignancy worldwide. In numbers, it is the 9th most common malignancy worldwide, but this ratio varies among men and women. In men, it is around 7 most common urological malignancies. However, in women, the number falls down to 17th. So a total big number of the grand total is the 9th most common urological malignancy. When talking about the histological subtype, urothelial carcinoma is the predominant histology. This histology is seen in the more developed part of the world, in the North America and Western Europe. However, in the rest of the world, because of other risk factors, non-histological variants are more common. I'm talking about schistosomiasis and the squamous cell carcinoma type variety in North Africa and sub-Saharan Africa.
Stones.
Right. So here we can see the globe, which shows the incidence rates. The darker blue area shows the higher incidence rate, and we can easily appreciate in this globe that in North America and the western part of America, the incidence rates are very high. So the grand total number of cases that were reported in the year 2020 were 500,000, 300,000 cases worldwide, with 212,000 deaths in total. So the worldwide age standardized incidence rate in men was 9.5. However, this is way lower in women, about 2.4. We'll see and look into the causes as to why this is present. This is a prevalent disease because of the treatment we're giving and the how this disease progresses. Around 1.65 million people in this world are living with bladder cancer. So with increase of level of development and traditionally lesser developed areas, better healthcare facilities, uh, we are able, the patients are expected to survive in subsequently increase in the prevalence. We don't really have our own numbers when it comes to Pakistan, as we don't really have our own national registry of bladder cancers. So, according to this GlobeCon, which is an initiative of International Agency of Research, they have estimated that bladder cancer is the uh, bladder cancer, ninth most common cancer in Pakistan. It is even more when it comes to prostate. So around 461, uh, 4,610 cases were reported. It ranks at number 10. We can also see that it is the mortality rates is 2,614, and it is quite a prevalent disease, more so than the prostate cancer. Reasons could be variable because we don't really register our patients. So this is not the perfect representation, but this is what we have. Here we can see the distribution of the global distribution of this disease. Uh, Men are way more likely to suffer from bladder cancers. The blue bar in every country is very big as compared to the pink bar, which represents the woman. Uh, the disease, the incidence rates are very high in Western Europe, and it falls down as we uh, progress into progressively other countries such as Asia and Africa. So let's start on the risk factors. We have seen a few risk factors, the non-modifiable ones that uh, um, uh, male gender are more likely to develop. As the age progresses and the age of 65, the risk factors greatly increase in the population. And some of the other risk factors are modifiable, in which we can, just by changing our habits, avoiding smoking, and changing our occupational practices, we can avoid bladder cancers. So, a word on bladder smoking. This is the most common risk factor of bladder cancer, which attributes to 50% of cases. Tobacco is a rich source of carcinogen, mostly aromatic amines and N-nitroso compound. So, how are these compounds affecting the uh, how are these compounds causing blood cancer? So these compounds actually combine with DNA, resulting in breakages in double-stranded and base modifications. So by these methods, uh, patients are likely to develop bladder cancers among other cancers. Summary on the literature as to how smoking and in which sense the smoking is affecting the smoking. Cigarette smoker increases blood cancer risk from 2 to 4%, with 30 to 50% of all bladder cancers are caused by smoking. However, there is a latency period of 20 to 30 years. Increasing intensity, increasing duration, all increases the risk factors. You can decrease the risk somewhat by quitting smoking, and you can actually approach the baseline by 20 to 30 years. Risk factor also depends upon the variety or the type of the tobacco that we are using. A black tobacco increases the risk threefold, whereas a blonde tobacco is much lesser. An unfiltered cigarette increases the risk from 35 to 50% as compared to a filtered cigarette. Deep inhalation patterns are increased with increased bladder cancer. Pipe smoking and cigar smoking are also believed to be a higher risk. Snuffing and tobacco, however, these risks are not really evaluated. After the smoking, we'll talk on the occupational exposure and how these are causing bladder cancers. So those industries in which the workers are exposed to aromatic amines, polycyclic aromatic hydrocarbons, chlorinated hydrocarbons are much more likely to develop. And of all the bladder cancer, 10% of these cases are attributed to these chemicals. So where are we going to find these chemicals? These chemicals are more workers are exposed to these chemicals when they are working in industrial plants such as paints and dyes and metals and petroleum industries. Here we can see all the risk factors of occupants and what specific chemicals these factories are producing that are putting our workers at harm. Aluminum productions, rubber productions, dye industry, coal tar industry, dry cleaning, hairdressing, printing, and textile are all associated with bladder cancers. So in developed industrial setting, just by reducing our workers to these risk factors, we can greatly avoid and we can greatly lower the chances of workers of developing bladder cancers. Next up, we'll see the environmental factors and how these are affecting bladder cancer. So chlorination of water. Chlorination is a common process in which we decontaminate the drinking water. However, the byproduct of this chlorination is a compound called trihalomethyl. This is greatly associated with development of bladder cancers and as such. Similarly, arsenic in water is also a big risk factor in developing bladder cancers. So when we are commenting on environmental factor, schistostomia hematobium is a parasite which is greatly linked with bladder cancers, and it is very prevalent in areas of North East Africa and sub-Saharan areas in the area of Nile Valley. So what it does is it enters into the bloodstream and it dwells into the bladder where it is a source of constant irritation. It acts there and hence cause of squamous cell carcinoma in those prevalent areas. So how bladder cancer is affecting the age and gender? We know that men are 3 to 4 times likely of developing bladder cancer as compared to women. What may be the reason? There is no uniform theory of how these different presentations occur and what is the behavior of bladder cancer between different genders. It is expected that men and choosing those occupational settings which are putting them at harm of bladder cancer. Smoking patterns may be one of the cause in men of why they're developing bladder cancer. A word on age. Median age of diagnosis of bladder cancer is 65. So age is the greatest single risk factor for developing single non-modifiable risk factor of developing bladder cancers and dying from it. Elderly patients face both clinical and institutional barriers to appropriate treatment and health, and hence they are likely of dying of bladder cancer. Similarly, women, although they're presenting at a low numbers in the clinics when it comes to bladder cancer, however, when they do present, they have a poorer prognosis as compared to men. There are racial differences seen in bladder cancer. Whites are more likely to develop or twice as likely to developing bladder cancer as compared to African Americans. However, similarly is the case. Women and non-white Americans report in more advanced cases and hence likely developing higher mortality rates. Studies have suggested that genetics do play a role in bladder cancer. Those who are slow acylators of N-acetyltransferase and those who do have deletion in glutathione S transferase are likely to develop bladder cancer as compared to those who don't have. Although first-degree relatives of patients with bladder cancer have twofold increase of risk of developing urothelial cancers, high-risk bladder cancer families are exceedingly rare. So we don't really have an overt data to suggest that there is a genetic predisposition of developing bladder cancers. Other risk factors include chronic irritation of the bladder, chronic cystitis, human papilloma infection, upper urinary tract infection, because the mechanism of developing cancer is almost the same. Patients who have undergone bladder augmentation are at a greater risk of developing bladder cancer, and we should screen those patients who have undergone bladder augmentation, especially those who have gone gastrocystoplasty. They are at increased risk of developing bladder cancer. Iatrogenic includes radiation therapy, cyclophosphamide, painkillers such as such as phenacetin and diabetes drug, oral diabetic, such as pioglitazone. One such important risk factor that we have included is aristotelic acid. This is a common herbal drug that our herbalists use in various medications. Painless gross hematuria is the single most important clinical presentation. We see that a lot in our clinics. So it is present in about 85% of patients with newly diagnosed bladder cancer. Microscopic hematuria is also present in nearly all patients. Uh, Unlike many other cancers, bladder cancer do present itself. So it is very rare that a patient uh, may have an incidental finding of bladder cancer. Uh, the presence of blood in urine is the most, as told, most common symptom of bladder cancer. Approximately 50% of patients with gross hematuria have an identifiable cause. And among these, the risk of malignancy is around 40%. In bladder cancer, typically the hematuria is intermittent, gross, painless, and may be present throughout the whole micturition. Pain is associated with a locally advanced or a metastatic disease, and the mechanism of pain is how it's disturbing its anatomy. So it's either the obstruction, the ureteral obstruction at the orifices, or it's the bladder outlet obstruction, or if the disease has advanced, it is causing the pain, and we may have the pain of due to its metastasis in other organs as well. Voiding symptoms are most common in patients with carcinoma in situ of the bladder. It may be due to functional decrease in the bladder capacity, reduced overactivity, invasion of the trigone, and obstruction of the bladder at the neck. So, when we have a patient who is presenting with painless hematuria, and we have the reason to believe that this patient is suffering, or maybe we should investigate in this patient, and we have excluded all the benign causes of hematuria. That's how we are going to work upon this patient. A complete history in which we should focus on his living environment, his social habits. Is he smoking or is he not? And what other important points that we can pick from his history is important. Physical examination, although it may be limited in non-muscle invasive bladder cancer, but it can tell uh, various details of how the patient is developing the bladder cancer. Other laboratory studies, in which includes urinalysis and urine cytology, and imaging, which includes CTs, ultrasounds, MRIs, and in the end, cystoscopy, which really is the gold standard of diagnosing the bladder cancer. So a complete urinalysis includes physical, chemical, and microscopic examination of the urine. Presence of blood, if not seen from the visible eye, it's called the microscopic hematuria. So it's normal for a person to pass around 3,000, 30,000 RBCs in the urine. So which represent as one high-powered field unit. A significant microscopic hematuria is 3 or more than 3 high-power field units, and it should prompt a proper investigation as to what is the cause of this hematuria. The other important investigative tool is urine cytology. So the idea behind urine cytology is that the cells that are malignant, they lose their adhesive capabilities, and hence the patient with bladder cancer are passing these specific cells in their urine, and we can see these urine cells under a microscope, and we can easily pick these bladder cancer cells, which can tell whether a patient is, or if he is or not suffering from bladder cancer. But one issue with these type of tests are they are not very sensitive. Their sensitivity is around 30 to 80% when it comes to diagnosing bladder cancer. However, a presence of a histological, a high grade or a suspicious high grade cell is very specific. So the specificity of these tests are very high. If we do have a sample um, of an aberrant histology, we should investigate in these patients as to why these cells are present in the urine. So the contemporary sensitivity and specificity of urine cytology in detecting bladder cancer ranges from 31%, and the specificity is 94 to about 100%. So if there is a high grade urothelial carcinoma cell, so there must be a tumor, and we should properly investigate. If the cystoscopy is negative for such patient, we should prompt an upper tract imaging and take random biopsies from bladder, prostatic urethra, and the urethral washings for cytology as well. These are some of the examples of what we are going to see in a microscope: a high-grade urothelial cells displaying all the features of malignancy, a high nuclear to chromatin ratio, a coarse chromatin, and on the other side, a suspicious high-grade urothelial cell, which is presenting as a deep blue against a white background. So due to the low sensitivity of urine, various other urinary tests were developed. So in order to increase the sensitivity of these tests, but these tests also have its own shortcomings, and because these tests are greatly affected by previous bladder treatments, installations, intravesical therapies as well. Urine biomarkers are useful adjunct in patients, but they lack the diagnostic accuracy, and they cannot replace cystoscopy. Some of the commonly FDA-approved urinary biomarkers are nuclear matrix protein and Eurovision and immunocyst. Imaging study may be used to define the location, extent of the disease, detect any multifocal diseases as well. So the guidelines suggest that we should use a renal and bladder ultrasound and CT-IVU urography during the initial work of patient with suffering from hematuria. So ultrasound, though, may have a moderate sensitivity to wide range of abnormalities, but we can with a accurately used ultrasound, we are able to distinguish the types of bladder growth, the exact location, whether or not hydronephrosis or obstruction is present, and the visualization of intraluminal growth in bladder. However, it cannot exclude the presence of upper tract urothelial cancers, and it is not a replacement of CT urography. CT-IVU or tomography is used to detect papillary tumors in the urinary tract and indicated, as we can see, by the filling defect. CT urogram is not limited to that. We can also diagnose if or not this disease has spread to other organs as well. So MRI is as reliable as CT for staging invasive or locally advanced diseases, or maybe even better when it comes to tumors or small tumors which are present at the base and dome of bladder. MRI with the gadolinium enhanced may be even superior to CT when it comes to detecting lesions and multiple tumors, extravesical tumor extension, and into the surrounding organs. Now, cystoscopy. So cystoscopy is the gold standard for the initial diagnosis of bladder cancer. Cystoscopy, when combined with urine cytology, may detect lesions that may be missed otherwise. So all the patients in which we have significant reason to believe that they are suffering from a bladder tumor should undergo a prompt cystoscopy in order to diagnose these lesions. So the traditional cystoscopy is done under white light, but it has its shortcoming. It may be good for a large growth, but it cannot really diagnose carcinoma in situ, and we are very likely to miss these smaller lesions in cystoscopy. So In order to improve our yield of cystoscopy and later during the resection, we have developed newer techniques, which includes a blue light cystoscopy, which really is an installation of this intravesical compound called amino-levulinic acid. So these compounds are greatly accumulated into the bladder cancer cell, and when viewed under the a bright blue light, we can easily appreciate how they are presenting, and they are appearing as a bright blue color, bright red color, which will help in removal or better removal of the disease. A similar technique is narrowband imaging. Narrowband imaging uses a specific wavelength of light, which has greater uh, uh, which has a greater depth into the bladder tissue and hence accentuate the visibility of bladder cells, enhanced visualization of tumor, and could potentially increase the outcomes of TURBT. NBI has been used as an alternative approach in an effort to improve the cystoscopy and the yield of TURBT. Even newer such modalities include optical coherence tomography, which is a real-time, non-invasive uh, technique in which we can easily pick the changes into the bladder microstructures of the bladder wall non-invasively. And SPICE, which is the Stokes Professional Image Enhancing System, which also increases the contrast and brightness of the setting, and it helps pick these lesions which are otherwise missed to a common eye. TURBT or the initial resection is the initial treatment. It is potentially curative when it comes to uh, uh, treatment of bladder cancer when it is done properly. We will cover TURBT in a greater detail in the upcoming module, but here's just a word because uh, it is a part of the initial treatment. TURBT or transurethral resection is the initial treatment of presumed non-muscle invasive bladder tumor, and a complete resection of all the visible tumor with adequate depth includes muscularis propria. The quality of TURBT is of prime importance. So, um, endoscopic resection or TURBT is potentially diagnostic as well as therapeutic when it comes to its yield. So the goal of TURBT in non-muscle invasive is to make a correct diagnosis and completely remove all the visible lesions. A successful TURBT should be able to identify or assign the disease risk, clinical stage of the disease, adequacy of the resection, presence of any complications. We should be able to measure the size and of the tumor and should be able to describe the characters of this tumor. We will study or focus on TURBT in greater detail in the upcoming modules. So, in conclusion, bladder cancer is a very common disease. When diagnosed early, we can easily treat our patients. But the idea is we should not miss these lesions. Early diagnosis could easily prompt a proper treatment as well. We should employ new techniques which are readily available to us in order to increase our goal. So, thank you very much.